Morning, everybody. It was nice to see so many of you yesterday. For those of you who are here for the first time, welcome to Iowa. For those repeat customers, welcome back. It's great to have this conference year after year. This is the 20th annual family conference. It's important to remember how this all began in a person's home. Two people grappling with a problem that had no solutions, no cures, no ways to go. And it started small, but you can see how much it has grown. And it's really thanks to the vision of Richard and Lynn. And it has now become, I guess, a movement of sorts that really has a worldwide following. I'm fortunate to be here and to play a small part in the overall management of C3G. So I'm a transplant nephrologist. That means I take care of patients who have a kidney transplant. And my role is to try and, if you will, demystify the process of a kidney transplant to the extent that I can, because that might be on the cards for some of you, and perhaps some of you are already there. So I've been given some objectives by Richard, and these are first, considerations for the donor. And here we're talking about living donors, understanding surgical risks, the emotional readiness, legal and financial planning, lifestyle adjustments, and long-term follow-up. I'm also going to briefly talk about considerations for the recipient. And the areas that I will briefly touch upon are choosing a transplant center, preparing mentally for what is to come, how best to be physically as healthy as you can be, and a little bit about medication education and medication side effects. I've been asked to speak about changes that are coming to UNOS, and I'll explain what UNOS is when I get there, and how that might impact your transplant decision and which hospital you might choose to go to. And then what type of donations are possible, daisy chain, living-related donation, and deceased donation. And then how do you make that ask? The ask here is how does one actually go about finding a living donor and asking a person to consider giving that gift of life. There are sensitive topics and how to broach them. And I'm going to show you one video that NKF has on their campaign, the Big Ask, the Big Give. There are many, many videos that are that cover this theme. And so I'm going to start with considerations for the donor. So there are in the United States about 6,000 living donors a year, and they comprise about 1/3 of all the kidney transplants done in the US per year. So they're a sizable portion of the total kidney transplant volume. And without living kidney donors, our transplant waiting list will get ever longer and longer. And it used to be that kidney donation only occurred between loved ones, principally siblings, parents, and children of affected individuals. But now with modern immunosuppression, pretty much anybody can give, and that can include a spouse, it can be a friend, it can be a total stranger. We have people that really have no idea who they want to give to, and they step forward saying, I have 2 kidneys, one of them I would like to give to someone, and will you help me find that person who I can give this kidney to? Typically, a kidney donation is at the center where their recipient is, so it's all local, but it can be a remote donation given to someone that you know. Perhaps your brother lives in San Francisco and you live in New York City. You don't have to necessarily travel, so you can donate remotely to the person you know. And then in the pair exchange system that I will briefly speak about, you can also donate to somebody that is determined in the exchange to be the best recipient of that kidney. And that is also something that can typically happen remotely. What are the benefits of a living kidney transplant? Well, first off, there are not enough deceased donor kidneys to go around, so we must have living donors. But really, beyond that, there's a lot of advantages. The surgery can be electively scheduled, so the recipient is usually getting his operation or his or her operation during the daytime, not necessarily on weekends, while with a deceased donation, we don't really control when the kidney becomes available, and the surgeon and the transplant center and the transplant team and the patient may have to be working in the middle of the night to make that transplant happen. More importantly, a living kidney always or almost always works immediately after a kidney transplant and generally lasts way longer than a deceased donor kidney. So if you had a choice, if you had no reason to have to wait on the deceased donor waiting list for that deceased donor kidney, and you had a living donor, from a transplant recipient's perspective, a living donor kidney would be better. And if you didn't know this already, this is among the most selfless and altruistic acts that one human being can do for another. And in this room, we have a couple, both of whom have been living kidney donors and have actually selflessly demonstrated what living donation is all about. So this is not necessarily the safest thing that you can do, but we as a society have come to believe that the amount of risk that is present in a well-evaluated, fully approved living donor is an acceptable risk, at least on the part of society and on the part of the transplant center professionals. And it is for us to make sure that the living donor is aware of these risks and fully understand what the consequences are, and that they're psychologically ready and are able to meet that challenge. So not every living donor candidate who expresses a wish to donate actually gets through our evaluation process. It is very, very rigorous. And it's not just making sure they're physically healthy, but it's also looking at their mental readiness, their caregiver support, their network of people that can help them through this, and so on. So it is a major surgical procedure. You're having a surgical procedure in your abdomen, so you will have generally almost all of the risks that come with any abdominal surgical procedure, that it can include bleeding, excessive bleeding that can result in the need for a transfusion, excessive bleeding that might require you to go back to the operating room to tie off a blood vessel that perhaps did not get tied off properly, or the ligature came loose. There may be blood clots when it occurs in a vein. We call it a DVT, or a deep venous thrombosis, which, among other things, can result in a fatal condition called a pulmonary embolus, where the blood clot in the leg may travel through the venous system and get to the lungs and cause severe illness or perhaps even death. You can have a scar from your procedure that can be painful. You can develop a hernia. The wound can get infected. And sometimes people that are in the hospital long enough can get a postoperative pneumonia. So there are some real risks that come with living donation, just like any other surgery. But these tend to be very, very rare. There are psychological risks. Not everybody is psychologically ready for a kidney that may go into their loved one and not work, or it might not do as well as planned, or the person that is donating was expecting a great relief from their emotional burden, and they find that they have not quite been satisfied with their own sense of well-being after their donation. So those are also important to clarify. There's an increased risk of preeclampsia. Preeclampsia is a fancy word for a specific condition that occurs in a person's pregnancy, where you have an elevation in blood pressure sometimes with increase in protein in the urine. It's not an excessive risk, but it's more than you would expect if you had not previously donated a kidney. We don't really know what the basis of that is, and that's again something we would tell women who are of reproductive age who are considering kidney donation. There's an increased risk of kidney failure. Despite our best efforts, despite all of the screening tests we do, people who donate a kidney have a increased risk of future kidney failure, much lower than the general population because of all the screening we do. But if you take a large number of people who are healthy enough to be donors and who don't donate, and you compare them with people that have donated 15 years later, there is a detectable increased risk of kidney failure. And that's also our task, to make sure that a living donor knows those risks. And it's for the donor to decide if that risk is too much, because even that fivefold increased risk is not substantially high risk depending on your point of view, because the baseline risk of kidney failure in the healthy population is so low. And then there's an increased risk of death. This is real. It's about 1 in 10,000. I told you we have about 6,000 living donors a year. So on average, we imagine that there's probably one death every 2 years, although I think it's much lower than that. This data comes from a while ago. There's a financial impact of being a kidney donor. There's some personal expenses of traveling to the transplant center. You have to stay in a hotel. If you have children, you have to arrange for that childcare. If you have to take time off work, there's lost wages. And all of that cannot be reimbursed. Although the recipient is allowed to reimburse those costs if it's related to donation, There are some ways around it. It depends on where you live and what you qualify for. But for example, we have in the state of Iowa something called the Anatomical Gift Fund, which can cover travel for a donor as long as the recipient is an Iowa resident. There's a national association called NALDAC, which stands for the National Living Donor Assistance Center, which was covered by a federal grant. I don't know anymore whether that's still well funded, but it can cover lost wages and travel for donors for non-Iowa residents, and that's available nationwide. We're one of the only states that have a state-based assistance fund. This is income-based, so those who are perhaps much better off do not get that assistance. There's an organization that organizes a lot of the paired exchange in the country called the National Kidney Registry. If the living donor is registered through them, they would cover lost wages as well and travel for any donor anywhere in the United States. And by the way, we have an Iowa law that if you're a state employee in the state of Iowa, you get 30 days paid vacation on top of your standard vacation. So you don't actually lose time when you take time off to donate and take time off to recover from that surgery. Not many states have that option. All of the medical evaluation, all of the immediate post-transplant, post-donation follow-up are all covered by the recipient insurance. The problem is the coverage after 3 months tends to be quite spotty, depends on the insurance company. Medicare only covers for the first 3 months, and all of the evaluation related to the pre-donation process and all of the perioperative and the hospital care is covered by recipient insurance. Depending on how much time you take off, you may lose your employment. You may have a significant loss of income. After the first 3 months, we would want to make sure that you continue to follow up with your primary care doc and get your blood pressure checked and make sure that your remaining kidney is working okay, but that's really at the donor's insurance or donor's personal expense. And anything that happens in the future that follows donation that may be remotely connected to the donation process may not be covered by the transplant center if sufficient time has passed. And that will also not be covered by the recipient insurance. So something to keep in mind. This is not meant to discourage living donation, just to be realistic about the things that we talk to every living donor about. All right, so we're going to move now to considerations for the recipient. How do you choose a transplant center? Well, the simplest is to choose a transplant center closest to home. It makes the travel easier. It makes follow-up visits after transplant so much easier. You'd really, if you have C3G, you want a transplant center with experience and expertise. So they've had, a long history of evaluating and treating patients with C3G, and they appear to have the expertise to do that. Ideally, you'd want a program that has an active living donor program, including a plan for paired kidney exchange. If the donor comes with an incompatible recipient, you'd want a transplant center that has high transplant rates, good post-transplant care, and excellent outcomes. Outcomes meaning, the kidney lasts much better than average, and the patient lives much better than average. We're talking here about the recipient. And then if you have the resources and the ability, consider listing at multiple transplant centers, especially if they're at least 100 miles apart. So if you live in Chicago, there's 7 transplant centers. You gain nothing really by being listed at all of them. But if you were listed in Chicago and you then came to Iowa City, you will be at an advantage because the allocation algorithm takes the proximity of the transplant candidate center with the hospital where that donor kidney is procured from a deceased donor. All right, and we've got a new allocation process that I'm just going to speak about where places with long waiting times are going to get shorter and places with short waiting times are going to get longer. It's an attempt by society to level the playing field because some people, unfortunately, depending on where they live, have inordinately long waiting times. And this is especially true on the 2 coasts. San Francisco, Los Angeles, New York City have among the longest waiting times. So what are the things you'd want to do to prepare for a transplant? You'd want to discuss with a nephrologist as early as possible. Keep in mind the eGFR threshold, and I'm sure this is all familiar with you. This is the filtration rate of the kidney. It's a measure of the overall function of the kidney. The E next to GFR simply means it's an estimation. It's a crude estimation, but it's an acceptable number when it comes time to getting on a transplant waiting list. And the reason that that number is important, you have to have a number of 20 or less. That means roughly 20% kidney function or less to get on a transplant center waiting list anywhere in the country and start gaining wait time. If you don't have a living donor, the single most important variable or determinant of when you get your kidney transplant is how long you've been waiting on the waiting list. So it's good to get in line as early as possible and mark your place. That waiting time can be transferred to any other transplant center anywhere, but you've established a place in line, and there's 110,000 people today on the kidney transplant wait list. You want to get to a transplant center, you want to take your support person with you, and you need to be aware that it can be a long process. Some places take 2 days to complete their evaluation. We attempt to do it in 1 day. And the reason it takes so long is you're going to meet a whole bunch of people. You're going to meet a transplant surgeon, you're going to meet a nephrologist, someone like me, a transplant nephrologist. If you have C3G, you're going to likely meet a second nephrologist, Dr. Nestor. You may meet Richard Smith. You may get additional lab tests. You'll meet a social worker, you'll meet a nurse coordinator, you'll meet a dietitian, a pharmacist, a financial counselor, and you're going to hear from Taylor pretty soon after this. You're going to get blood tests, you're going to get x-rays. You'll sometimes see a clinical psychologist. You'll sometimes see extra specialists, a cardiologist, a complementologist. You may need a CT scan, a stress test if you're older. And so all of this then takes a lot of time, but we try and accomplish this all of it in 1 day. What do you need to do preparing for a transplant? Well, you need to be aware of the difference between dialysis versus a transplant for C3G. Sometimes after your visit, there may be additional tests that you need to do. You don't have to do them all at the transplant center. You can do them and follow up at your local center. Vaccinations are required, a whole bunch of vaccinations. And if you've got C3G, then you also need to be vaccinated against the bacteria that may be a risk for you if you get one of those complement blocking drugs. You'd want to know what the treatment options are if disease comes back, whatever the disease is. In this case, we're talking about C3G. You want to get on the wait list. You want to maintain a decent hemoglobin. And we have drugs like EPO to maintain that hemoglobin. It's your time now to start thinking about a living donor. And if you find a living donor, then you would have that living donor contact your transplant center. Be sure that you keep your contact information up to date if you're on the wait list. If you get sick, you want to let them know. If you're taking a trip to the Bahamas, you'd want to let the transplant center know, because it'll be difficult to get you to the transplant center if a deceased donor kidney became available. All right. Now I've been asked to talk to you about changes to UNOS that are coming. Actually, those changes have already come, so I'm going to tell you where we are today. So what is UNOS? UNOS is a quasi-federal organization that has the contract to operate what the federal government calls the Organ Procurement and Transplantation Network. That is, in federal law in 1982, the government said there shall be an OPTN that will bring order to the transplant process, determine what the priority list for transplant candidates are, how organs are procured from deceased donors, and how they get to the transplant center. Until 1982, there were no rules. Anybody got transplanted by any donor that they could procure from. So that is the network in federal law, which they then contract out to any organization that appears to be capable of fulfilling that network. UNOS has been continuously holding the federal contract ever since it came into being. So it's considered sort of synonymous. If you say UNOS or OPTN, you're really meaning the same thing, but UNOS is the organization running the OPTN, if you will. Who is UNOS? It's a member organization composed of transplant centers, organ procurement organizations. Those are also non-governmental entities that have a federal contract to procure organs from deceased donors. And then the histocompatibility labs, the labs that do the tissue typing of the donor and the recipient and decide about the allocation algorithms that match a donor to a recipient. And in the past, so this is the past now reflecting changes that existed prior to 2023. The OPOs typically had a region that they covered, and the organs went to the region that they covered. So for example, here on this screen is a map of the United States. Let's see if I can find my pointer. And each of these colors represent one OPO. Generally, an OPO is state-based and covers the entire state. So the Iowa OPO is the Iowa Donor Network, but some states have multiple OPOs, including OPOs that have territories that are non-contiguous. And so the OPO used to recover an organ in their territory and allocate it preferentially to a recipient waitlisted at a transplant center within the territory. So that's how it used to be. Now, and the problem with that was that this is now a reflection of transplant rates. How efficiently are people getting transplanted at different parts of the country? The darker the color, the better the transplant rate. And you can see in Iowa, we have the darkest color, perhaps only matched by Utah, because our patients wait a shorter period of time and are transplanted at a higher rate. Whereas in, say, a place like California, some parts of the East Coast, Hawaii, the transplant rate is much lower. And that's because of the previous allocation rules that gave preference to local candidates. Now we have a new system where the kidneys are going to be allocated preferentially not to the geographic area that you live in, but to a 250-mile circle around that donor hospital where that deceased donor is procured. And so eventually the goal is to get to a continuous distribution model. That is, a kidney procured in Iowa City should be available to anybody anywhere in the country. But we're starting with 250-mile radius. It'll go to 500-mile and eventually nationwide. And the idea here is to reduce penalties for people that happen to be in areas where donor organ recovery is low, where living donation is low, and the population is large and waiting times are very long. So in San Francisco, the waiting time for a deceased donor kidney is somewhere between 13 to 15 years. So that's how it used to be. So now if you get a kidney from, let's say, a person who dies in Iowa City and a kidney is procured, now it can go to any transplant center anywhere within a 250-mile circle. So that includes Iowa City, our hospital, Chicago hospitals, Madison, Wisconsin, and Omaha, Nebraska. And you can draw concentric circles around every donor kidney, and the person listed at that transplant center gets the highest priority because the distance between the donor hospital and the transplant hospital is 0 miles. All right, so what types of living donation are possible? So those changes to UNOS are all about deceased donation. What types of living donation are possible? As I told you in the beginning, you can donate directly to your loved one, or you can have us, the transplant center, or organizations like the National Kidney Registry attempt to find you a different recipient in exchange for that recipient's donor becoming the donor for your intended recipient. So, in principle, then, if you don't have a match with your intended recipient, your sibling, your spouse, then that incompatible pair shown in this color who can't donate to each other and another incompatible pair who can't donate to each other, you can exchange, if you will, kidneys, where this person's kidney comes to this recipient and this recipient gets a kidney from this donor. In this system, which is the conventional form of exchange, you just exchange between 2 people or 3 people. It's conventional, it's simultaneous. So surgery is now starting in different parts of the country simultaneously on the donor because those kidneys need to travel to wherever the recipient is. And it's a closed loop. So there's nobody left standing. Everybody is covered in the system. It can be 2 pairs, it can be 3 pairs. It's a concept is the same. Here's one donor recipient pair, another donor recipient pair, and a third one. This is the recipient who can't get a kidney from this donor. Instead, it goes down this way. And this also is a closed loop, also simultaneous. And this type of loop can sometimes have 20, 25 different donor recipient pairs, all having surgery near simultaneously in different parts of the country. There's also this more linear approach, and this is called the chain donation. It requires a non-directed altruistic living donor who has no intended recipient to start the chain. So here are the pairs of incompatible donor and recipients. The non-directed donor donates to one recipient, his donor donates to this recipient, her donor recipient donor to this recipient. And then there is another donor who does not yet have a recipient to give to. So that's the end of this open loop that can start a second chain. And so it always requires a non-directed donor. At the end of the chain, this donor is available to start another chain. So in a sense, this is called a non-simultaneous, extended, altruistic, never-ending donor chain, or a daisy chain. And this, unlike that, is an open system where it can keep continuing. But you can break this up in time, so it does not happen to have the next chain starts at a different point in time. How does the donor kidney get to a recipient in this paired exchange system? The simplest option, I hope that's not my time marker. The simplest option is when the donor and recipient are different centers. The recipient can travel to the donor center to minimize the travel for the donor, but it's taxing for the recipient, or the donor travels to the recipient center. It's inconvenient for the donor. And if the donor has a loved one who he or she wanted to donate to, that person really wants to stay by the side of that person when he or she gets the kidney from the other donor. So that travel is really not optimal. So how we do it these days, for the most part, where neither the donor nor the recipient need to travel, is that the donor kidney gets procured locally, just as it would for a local kidney transplant, and then gets, if you will, shipped to the other transplant center. So there are donor kidneys traveling in boxes of ice across the country to fulfill this paired exchange. And this has become the preferred method. All right, so this is my last slide, and this is about how to broach that sensitive question, finding a living donor. So you want to learn as much as you can about living donation. There's a lot of resources on the internet. I'm going to show you 3 reliable sites that you can go to. Those are not the only ones, but I think you'll get plenty of information there to educate yourself. If you can, you'd want to talk to others who've had a living donation or a living donor transplant. If you can, you'd want to talk to former living donors to get a sense of their experience. You don't have to be the people screening them to ask them if they're healthy. You just need to find someone who wants to be a donor, and then the transplant center will take care of the rest. You'd want to spread the word that you are, in fact, on a transplant list, that you're on dialysis, that your life will be a lot better if you got a kidney transplant. Find ways to disseminate that information, maybe a county fair, maybe in your local church. You'd want to find ways to tell people who may want to know, who may not even know you, that you do want a kidney donor. And then you can go to these resources. So I'm going to see, hopefully Jory has made this accessible. So the National Kidney Foundation is the largest private nonprofit patient advocacy organization for people with kidney disease. You can go to their kidney learning center, if this will work. Will it? Yes. No, it doesn't. No, it does. So you go to the Kidney Learning Center. Let's see if I can move down. So if you just scroll down the list, you will see becoming a living donor for living donors, finding a living donor for transplant candidates who need a living donor. And this is pretty simple. You go there, and basically what they have are some teaching videos. You have to, register a simple process. And here are a series of simple teaching videos that you as a recipient candidate can go through to understand the process. And included in that is finding a living donor. So that's one example. Here's another one. So I talked to you about UNOS already. If you go to the UNOS website, and I put a link here for you, but if you're going to search for the Kidney Learning Center for NKF, you're going to search for about donation for UNOS. And if you go there, let's see what we get here. So yeah, up on this corner, you'd see about donation. I can't see this very well. There's living donation, and then there's a whole series of information about living donation, and here including a link on how to find a living donor. And then the third organization is the National Kidney Registry, whose only business is to help facilitate paired exchange. So they're all about living donors, probably the most living donor friendly site. And if you go there, you would want to go to for patients and go to, for example, microsites, tools to find a living donor. And then I'm going to very quickly end, since I was asked to do this, if I may, just a couple of minutes of a video. So this is the Big Ask, Big Give.